Hey, welcome to Renew Education. This is another case study. We're going to call this one the left side gap. The reason why I call this the left side gap is just because when I look at a CT scan, I just instantly have a thought on it. So after you keep looking at CT scans over and over again, or panos in this case, we're looking at the pano version of the CT, is that vertical dimension just jumped right out of me. So this left side has this really big gap between the bone arch up here and the bone here. And to look at the treatment assessment, let's look at that real quick. The treatment assessment looks like the bone density is an orange, the IA nerve is a yellow, the sinus is a orange, has yellow constriction and orange facial bone. So, you know, orange facial bone, sure. We don't have any teeth here to worry about. The reason why I put orange on there is because you have some teeth that actually look like they're pretty good. They've got a nice solid piece of facial bone out here. But if I look at some other teeth, not so much. Let's look at number 9. You're starting to thin it out here, and you might even have a fenestration if you took that out. But what I don't like is an angulation here, because your implant's going to have to go into the bone, and you'll try to keep it as angled as this to get you lessen the degree between the implant and the actual crown. So that's why I would say, you know, this is kind of an orange on the facial plate. So let's look back at what we're talking about. We're only going to talk about the upper arch here and how we're going to help restore this. I believe this tooth is hopeless here. And I think this one has recurrent decay. So we're actually looking at these here as much as anything. So let's look at what we've got here. We've got some bone here. If we look at that density, you can see the bone. It's more dense than the tissue around it, and you have a decent amount of height. So you got 8 millimeters there. Your width is not as great, but you know it's a 10. So you could do a 5 by 10 here pretty easily. Do a little sinus bump. That's less than 2 millimeters into the sinus, so I wouldn't have any problems just not charging the patient, just doing a sinus bump in that particular area. That would be there. Let's see. That's actually closer to 30. No, that's 14, yeah. So that works out pretty well for the patient. Your implant will be here, and you're looking at having, let's say if you did the 10, your coronal portion is probably going to go out to about a 12 at least. So this is where the implant to crown ratio is a little bit top heavy, but not too bad. Should be okay. The lower, like I said, we're going to talk about that more. If this patient starts losing these teeth over here, let's look at that. This is now becomes more of a challenge on what exactly are you going to do. Are you going to do an immediate placement? Are you going to graft? Are you going to pull the tooth, do a graft, place the implant? Like what exactly are you going to do here? So let's take number 12 right now. Take a look at that. So we've got a little bit of thin facial plate here, and you can see where things are a little bit in trouble right here, and he's lost some of that bone right here. So yeah, that's not great. So you've got this angulation. You could do an immediate placement. Let me just see. Let me put an implant in there and see what we could do. If I did a 4.2 by 10, that's usually my go-to premolar size, sometimes 11 and a half. If you do something like that, the problem I have with immediate placement here, that's a very difficult placement. And the reason why that's a difficult placement is because you want to stay away from the facial plate. You want to go into the bone, but you got to try to maintain the angulation in which the load is going to be loaded on. So you're trying to maintain it to kind of a little bit more to what the native crown actually is. So you can see that crown here, and you want to try to keep it there. So why is this difficult? It's because of this socket site being right here. Okay, so let me see if I can delete this out. Get rid of this. Okay, so let's get rid of, well, all right. So here's the implant placement going in right here. The socket site wall is right here. So to drill into this kind of angle is very difficult. And to get it to be in this position and hold when all of this part of the implant is going to be out into the socket, it doesn't have all the walls that you really want. It has some of the walls, and you're not quite, one of the rules is to have the implant into 4 millimeters of bone all the way around, and you certainly don't have it. But let's just see where 4 millimeters actually is. So we're at 4 or 5 right here. So you're just getting it into that realm, but you really have a tricky entrance to try to get that drill just exactly like that. So here's something that you might think about doing then. I have a 10 millimeter implant in here. What if we changed it to another implant? So let's see if we can do that. I don't know why there's no, here we go. It must be the next one down. All right. So in this case, we may be thinking about putting in, let me get rid of some of these lines, too many lines. A longer implant, so you get more fixation right here. You have a gap here. You may consider grafting with some sort of thin, cortical, mineralized medullary bone packed in here, or some other bone grafting material that you can get into this gappage here. That might be helpful, and then suture it over. You definitely want to bring this below the lingual bone for sure. You might even want to go a little deeper here, just because your facial bone is way out here, and you don't want that to collapse too far. So if you're going to go for a kind of tricky implant placement, this is it. That's for sure. So this isn't for beginners. This isn't something that you would want to do if you haven't done a lot of implants to try to get this one right. Doesn't mean you won't be successful. It means that it's difficult in the surgery, and you're going to learn a lot from this case in trying to get that angulation done. And I explain in different videos how to actually get it done. But it's the fixation that you're looking at doing and making sure that there's no micromobility to that implant once you've placed it. So that would be that case here. That would be this implant here. So let's see. Then you would do another implant here, and you can do a 3-unit bridge for the patient there if this is now the hopeless tooth. So this is kind of one of those discussions with the patient. Do you want to take this tooth out so you don't have any future problems because they have decay going on around this crown, and you don't know what you don't know, so when you cut that crown off, what are you going to do? So let's look at this tooth here. What if we did 3 implants in a row? What if the patient wanted that? So now you've got more facial bone here, that's fine, and now you're lessening the lingual bone, but for sure you don't have an immediate placement scenario here. You've got too much bone missing once you have the socket site. That's already 7.5 millimeters diameter just on the crown or the root that you have right now. You don't have a lot of thick walls, and then you won't have a lot to really go past. You don't have an option. You're going to go into that sinus area, and doing a sinus graft is not going to be fixing it well. It's not going to hold it well, and then you're going to try to graft all around the thing, and it'll be a big mess. So in a case like this, if I were to put an implant into this area, I would be looking at it as taking it out and grafting it, maintaining the facial plate, maintaining the lingual wall, and now you have a much, much better situation where the graft fills in and it hopefully heals all through. And then you've got a straightforward shot to do an implant without having to worry about failure or anything there. So we're looking at this case in just on the upper, on that upper left side. So this would be pretty good to just think about that in terms of the lower. We're going to get to the lower in a second. But outside of that, it's pretty straightforward. I like the case. This isn't a real beginner case at all. This case is going to be somebody that is getting to some more advanced techniques where they want to do sinus bumps, crestal approach type stuff. You want to challenge yourself maybe with an immediate placement one. If you've done a number of them, that would be this case. But outside of that, you could also be more conservative. You can take those teeth out. You can graft them, let those heal appropriately. You can do a sinus augmentation crestally and not place the implant in if you didn't want to. Make sure that the graft stays there, and then just do pretty straightforward implant dentistry after that. So you can simplify the kind of groundwork with the bone earlier on before getting into doing a surgery where you're trying to do it all at once. So don't think you have to always rush everything into a case. It's not necessary. Patients are going to be patient as long as they're trusting you, that you explain to them why you do things the way you do it and why it's really better for them. You always, always, always have to keep them first and foremost in your mind and in your heart and in their presence, so that they understand that you're looking after their best interest in whatever you do. So thanks for joining us. That's another case study for you. Stay tuned. Look for the lower version of this one. And like us on Facebook and subscribe on YouTube. We appreciate it. Check out for our live broadcast.